Right. Thanks very much. And I also would like to acknowledge the traditional owners of the land we're meeting on and pay my respects to the elders past and present, and also acknowledge the significant gap in health and life expectancy that Aboriginal people suffer in Australia, especially related to type 2 diabetes. So the goals of self-management really are to develop self-esteem and confidence that enable people to make good decisions about their health. It also means that self-management supports more than simply providing information, but also, I'm just flicking through these, encompasses reflection on their illness, goal setting, regular follow-up of patients to monitor their progress. We know that simply providing education isn't enough to enable a person to actively manage their condition. You can't read the writing on the cartoon. It says, Ed is in a study involving diabetes and a lack of exercise, and this is the remote control group. So health literacy is a major determinant of our ability to self-manage, and in particular, the ability to self-manage in type 2 diabetes. And there's some significant barriers to this that occur, particularly related to people's ability to not just their educational background and their ability to understand their condition and the management, but also cultural and language barriers as well, and geographic barriers to accessing services and education. There's a number of different ways to measure health literacy, and this is one of them. This is an Australian scale called the Health Literacy Questionnaire, which is developed by a number of people, including Richard Osborne in Melbourne. And it's quite a lengthy questionnaire, but it's got 9 scales, and it's possible to use components of that questionnaire rather than having to administer all 44 questions. This has been useful in our research, looking at the interaction between health literacy and self-management. So we have looked, this is from a study looking at a study of people who are in general practice, who were overweight or obese and who were attempting to lose weight as part of the study. And the domains that were the lowest scores were those that related to actively managing one's health and being able to critically appraise health information and having sufficient information to manage their health in this group. So this was a group of patients who, despite feeling actively engaged with the healthcare providers and understood and supported by the healthcare providers, still had some significant barriers. And the 3 domains, though, that were most important in terms of people actively managing their weight were these bottom 3, the having sufficient management, being able to critically appraise health information, and feeling able to actively manage their health. So we found that those were most closely related to people's ability to actually manage their weight. So we conducted a study in Southwest Sydney, which was about evaluating the impact of a primary health network web-based patient information portal that was for patients, designed to be used by patients and their families, but also in particular designed to be facilitated by GPs and practice nurses as part of their consultations, and to enable them particularly to access appropriate services that could support their own self-management and improve their confidence. It was a single group trial evaluated using both qual and quant methods, and involved 10 general practices in Southwest Sydney, all servicing low socioeconomic populations and in areas of low socioeconomic status. The intervention was at 2 levels. Firstly, at the level of the practice, involving some quality assurance measures like such as audit and training and practice support visits from the PHN. But at the clinical level was structured around a health check visit to the practice that was structured across the 5 A's with an emphasis in the 5 A's on health literacy. So not just assessing their risk, but their understanding and capacity, providing advice and goal setting, demonstrating the website as a tool that they could use to self-manage, and arranging referrals as appropriate. So this is an example. This is the landing page for the support tool, which you can go and see on the South West Sydney PHN website, still there. And there's one in English and in Arabic, and each page, each one of these tiles contains information primarily around places people could go to get information, get services and support. And this is the sort of information that's available. It's not exactly what it looks like, but it's similar inside contact information about referral services online, but also referral options for people in a local area. So each one of those tiles has that kind of information. These are some of the participant characteristics. We recruited patients with type 2 diabetes who had poor control and who spoke English or Arabic, and they were aged between 34 and 77, and we collected some usable data on about 85 of them. And of these, only a proportion, despite reminders, actually attended for a health check, and I'll talk about that a little later. Internet use, most of the sample, despite being older, already used the internet quite frequently and felt quite comfortable about finding information on the internet. About half of the sample had used the internet to find information about their own health in the previous 5 months. So relatively internet literate group of patients. So this is their health literacy on 4 of the scales of the health literacy questionnaire. Their ability to get information when needed, that was one of the things in the bottom. To find health services, which was people were a bit more confident in that previous graph I showed. To decide which healthcare provider to see, and to be able to feel comfortable about having their health problems and explaining those to a health professional, and the ease with which they felt they could do those things. And again, you'll see that there's a bit of a skew towards in the first 2, the first 3 towards having a little bit of difficulty, but the majority of patients felt that they were had relatively good health literacy. So in the health check visits, this is the web pages that were actually the nurses or doctors went through with the patient. And so this is how frequently they looked at the individual web pages. And after this, patients were encouraged to use it at home. And website views increased over the period that the patients were having their health checks. Interestingly, there was a difference between the English websites, where there was focus on diabetes services, blood sugar control, weight management, and foot and eye care, whereas the Arabic sites were being predominantly used for things like diabetes terms and which diabetes services were available. So obviously more basic issues for those patients who were using the Arabic site. They were more concerned about their ability to understand their healthcare provider and what they were recommending, and just what services were available. Whereas the users of the English site were a bit further down the track on the self-management pathway. We assessed their ability to access appropriate information, particularly, so their ability to perceive or seek information, both quantitatively and qualitatively, And interestingly, so there was a shift in their ability to measure this. This was using a questionnaire scale that was developed as part of the study. And the providers tended to shift their emphasis from focusing just on motivation to thinking about whether patients really understood. There also was a trend towards patients reporting, sorry, move one forward, on a scale of 1 to 4, their ability to explain their problems to the health professionals. And again, there was a modest shift towards improving that. And GPs and practice nurses reported that there was improved interest. However, they were quite concerned about how long that would be sustained. So there was some interesting issues that arose out of this fairly limited, small study that we conducted in South West Sydney. Particularly the low health, there was a real problem with getting all of the patients in to come into the health practice for a health check visit. So this was not a routine diabetes care visit. This was an extra visit, or extra 2 visits actually, that we're asking patients to have, which they didn't have to pay for. There was no cost to them, but clearly was something that wasn't part of their usual care. And we were surprised that about a third of the patients were reluctant and quite difficult to get to come into the health check visits, and they were likely to be the patients who were the least health literate. And that was despite most being comfortable with the idea of the internet and seeking information on the internet. We did notice some ability to perceive and engage in care, and this had some positive effects on the roles of staff, especially practice nurses. And this fairly simple, limited intervention seemed to be received quite well by teams, but it had really, there wasn't, despite the tool and the information in the tool, it really didn't have much impact on their linkages with other services, their ability to communicate and to liaise with other services. The website's a simple intervention and low cost, and the PHNs maintained it because of its low cost. And of course, the problem, of course, is that the health check visits were facilitated by the study, and they're not routinely funded as part of Medicare for Australian general practice. So although the practices have all said that they've continued to use the tool after the end of the trial, just how much they're using it and the extent to which they're able to spend time with patients going through the website is unclear. But that's something that we're able to sustain. So that's all I wanted to say. Any questions?
Why was the linkage to other services not happening? What was the
barrier?
Barrier.
Well, it wasn't a specific component of the intervention for a start. We did put a lot of effort into training the GPs and practice nurses, but and providing them with resources and materials and information. But a lot of that training was done online, and there wasn't any kind of face-to-face interaction with the referral services, which I think in retrospect was an issue. I think GPs tend to refer based on personal relationships and personal communication, and unless you can alter that, it's quite difficult to get a change. Arranging that sort of interaction, though, is not easy, because whereas some of the private providers, the dietitians and exercise physiologists and so on, who might be getting referrals from GPs, particularly as part of their care plans, the small organisations that were running group programs for physical activity, for example, or education programs, again, most of which were in groups, didn't really have the resources to kind of visit practices or invest a lot of time in establishing relationships with GPs. And it is quite difficult to get through to GPs. And that's something that's becoming more of an issue as the practices get larger and practice managers become more resistant to having people approach GPs. So I think there's a lot of reasons, but there's some of them.
Were GPs allowed to use GPAP or TCA?
Yeah, they were in these. Sorry, the question for those online. Able to use the care plan items, the team care arrangements or GP management plan arrangements. They were. Not all of these patients qualified. Some of them already had those items expended for other reasons, for example, foot care or whatever. Yeah, some of them weren't really claimable for that purpose. But yes, we and quite a few of the patients did get a care plan as part of this process.
How would you say that the impact of this intervention compared to what the impact of something like health coaching, other kinds of self-management?
Well, it's fairly light. I think that the impact was, this was a fairly simple, brief intervention, very low cost compared to, say, the Get Healthy telephone coaching line, which was one of the options that people were provided with, of course. But the actual number of referrals that went to the telephone coaching was quite low. Yeah, so I think this is much lower cost, lower intensity, and therefore we weren't expecting radical differences in their HbA1cs. We did see a decline in hospital admissions, which was significant in this group of patients, but again, the numbers were relatively small, so we're not sort of emphasizing that too much. Yeah, the way we saw it was this was potentially one component of an intervention where we might be able to improve access for some of these vulnerable patients rather than something that was really a comprehensive intervention that we expect a huge impact.
It's time for one more question, and just ask Mark.
Yeah.
So, given the population, was there any assessments of apart from health literacy? Was there any assessment just of reading index of literacy levels and the reading age of the text on the website?
We did assess the reading age, and we did the flesh and what are all the different reading age assessments, and we structured it to do that. Not just for the limited information that was available on the website itself, but the services they linked to as well. We tried to link to low literacy websites, or in the case of the Arabic, to services and web pages and information that was in Arabic. But in terms of the patients themselves, no, we didn't assess their own literacy.